Hi, my name is Dana, and for my healthcare issue project, I decided to talk about the unsafe staffing ratios present in skilled nursing facilities. So, skilled nursing facilities, commonly known as nursing homes or SNF, play a significant role in healthcare operations. There's about 15,000 facilities across the United States, and they serve as a safe setting for patients who no longer need those acute care services, but they might not be ready to go home yet and require rehabilitation services. So that includes physical, occupational, and speech therapy. Some nursing homes may even specialize in like specific types of care, like dementia care, trachs and vents, NG or G tubes, or even bariatric care. So as we can infer from the name, the nursing workforce primarily focuses on performing those clinical skills like wound care, IV therapy, medication management, as well as patient assessment and care planning. So these transitional healthcare settings serve as an essential part on the healthcare system because they alleviate that strain on those hospitals. So it allows reduced hospital burden and workload by coordinating that continued care for lower acuity patients. So that reduces length of stay, readmissions, and overcrowding. It allows those hospitals to free up those beds and focus their resources for those acutely ill or critically injured. So, while SNFs can help promote safety and recovery for patients with shorter length of stays, they also provide that long-term care service. Those are for patients who need extended ongoing support because of complex medical conditions, or they need assistance in their ADLs because they have a decreased functional status, or even just limited social support. So in turn, these affect population health level outcomes. They support overall community healthcare outcomes by addressing those healthcare disparities and ensure care is accessible to those vulnerable individuals. So these SNFs employ a range of nursing professionals, including RNs, LPNs, and CNAs. RNs are usually supervising both LPNs and CNAs, while LPNs are more direct and hands-on, like giving out meds, assessments, monitoring progress. Those CNAs are the ones that assist with ADLs, get vital signs, and they report to the LPN. So theoretically, the staffing models allows management of patient care across distinct roles. But in reality, we're competing with higher or increased workloads with higher census of patients. And without those staffing safeguards in place, the reality of the current workplace actually differs from each nursing home to nursing home. And they challenge that safe patient care. So how does that look like? For instance, there's been studies that show that lower coverage for RNs actually increase the incidences where patients acquire pneumonia, DVT, and pressure ulcers, which these hospital-acquired conditions actually contribute to longer hospital stays and actually have higher costs of care. And there's another study that showed rationing of nursing care actually increased the incidence of med errors and bloodstream infections. So there's quite a few of them around that show how insufficient nursing coverage and workload pressures can actually directly impact patient outcomes. But a lot of these studies and research actually focus on hospital settings, and they fail to include how these staffing challenges manifest in skilled nursing homes. So I included this because I thought this was an interesting piece as someone who has spent a few of their nursing career in a nursing home. So with the recent changes on CMS staffing requirements, facilities may staff below previously recommended levels, potentially increasing the risk of these adverse events like med errors, falls, delayed care. So this exemplifies how legislation directly impacts nursing care practice and patient safety. So these nursing homes may now staff below those federal minimums. I believe, if I'm remembering correctly, they are no longer required to have 24/7 RN coverage. So these vulnerable populations may face lower quality of care due to insufficient staff. And depending on each state regulations, facilities may choose to establish their own policies on staffing ratios. These companies may benefit to cut costs towards staffing and maximize their profits by only staffing what's minimal to them. So there are ethical implications that come with unsafe staffing ratios. It conflicts with the ANA Code of Ethics because it forces us to be task monkeys rather than focusing on individualized patient care. So there's that deficit in that direct patient care and attention that can pose that harm and violate our ethical duties to protect the patient's dignity and uphold integrity. So we're also sacrificing quality of care over volume of patient care, because when the focus is on seeing a higher number of patients rather than actually ensuring that there's quality in it, these nurses may give precedence to time management, and we end up omitting safety guards, critical checks that decrease that safety standard. And lastly, there's moral distress when a nurse is unable to fulfill their duties due to competing demands. So principles of beneficence, non-maleficence, and justice are jeopardized because when staffing compromises a nurse's ability to fulfill their duties, that causes more of a moral injury. I remember feeling and sharing that feeling with coworkers that I don't feel like I gave the best care. So those are some examples. On the other hand, there's also legal considerations for unsafe staffing ratios. I included a picture of the recent New York nurses strike because I think that is just a symptom of a larger issue at hand. So it infringes on patients' rights to receive safe and competent and timely care. Because inadequate staffing often stretches the nursing staff's abilities to provide that care assigned to each patient. So it delays interventions and decreases the medical treatment and compromises health outcomes. It also violates required standards of care under the Nurse Practice Act. While Arizona's does not explicitly state mandated staffing ratios, it upholds professional standards. So insufficient staffing that results in delays or omissions in patient care may compel those nurses to practice outside these standards and potentially violating the act. So it's kind of a gray area, but it's still focusing on safety or the lack thereof. And lastly, it increases risk for malpractice and negligence and threatens nurses' licenses. So limited staffing models present in skilled nursing facilities already create that unsafe working condition. So even with the best intentions, systemic issues in place may place nurses in situations where providing adequate care is challenging, or it potentially results in non-compliance with legal standards. So not only does unsafe staffing endanger patients, but it also places nurses at risk for both professional and personal. So the ANA Code of Ethics states that the nurse advocates for the rights, health, and safety of the recipients of nursing care. So as nurses, prioritization of care is one of the many phrases drilled into us early, right alongside with critical thinking. So how we distribute the number of staff across limited time, supplies, and resources ensures that patients with the most urgent needs receive the immediate attention. So that obligation to identify unmet standards of care as a result of staffing inadequacy is actually part of our professional code of ethics, because it allowing unsafe ratios violates our duty to prevent foreseeable harm and manageable risk, right? So equitable assignments help ensure safe care and interventions are provided in a timely manner, and that we fairly allocate care to those who need it the most. So that demonstrates that ethical decision making in practice. So why does it matter, right? So safe staffing rather optimizes balanced and manageable workloads that produces burnout and fatigue. It allows us nurses to confidently address patient care needs and balance our role demands while managing that day-to-day nursing activities and responsibilities. That unequal division of work creates that time scarcity, and that results in that missed care, errors, and eventually moral distress. It also promotes, or safe staffing also promotes, therapeutic relationships between clients and healthcare professionals. So as family members at bedside, having the staff, it promotes that clear communication, reassurance, and ultimately reinforcing that trust in the healthcare team, because they know their loved ones are safe and they're being attended to rather than feeling neglected. And safe staffing also supports patients, ensuring that their needs are met and their concerns are addressed in the plan of care. All of that to say, it really is in a matter of, or in focus of having these care and interventions being delivered in a timely manner. Because considering the amount of time needed to complete care without compromising safety and worsening health outcomes, there's just so much to do in so little time, right? And I'd like to reinforce that point about families and the patient's social support, because without that support for family engagement or even our limited presence, they might have important concerns or questions that may be left unanswered. So that results in knowledge deficiencies. So they might not understand how to take care of their loved one when it's time to discharge and go home. And so all of these preventable complications go overlooked. And we ultimately compromise and readmit and all that. So the ethical theory that I chose to navigate this healthcare issue is through utilitarian ethics. Basically, safe staffing supports both patients and staff. They promote the greater good by ensuring safety for patients and also safeguard the staff's well-being. So I'm going to read the key idea here. Unsafe staffing practices negatively impact nursing practice and patient care. By reinforcing higher staffing levels, healthcare organizations support safe, effective care and staff well-being. So we're addressing falls and fall-related injuries. We're decreasing those hospital-acquired conditions, and that includes those pressure injuries. We're allowing these nurses to utilize their education and make sure that there's time for those safety checks, reducing safety errors and focusing on assessments that ultimately reduce hospital readmissions. And also for nurses, especially I feel like new grads, if they're entering or starting out their career in this type of healthcare facility, practicing in a safe working environment where you feel good about the work that you do and that you weren't pressed for time in delivering care for a patient or feeling like you've neglected another, it supports your moral character and it makes you want to stay and work, and it retains staff. When staff is feeling like they can do adequate work or deliver adequate care to their patients, it reduces that feeling of burnout and ultimately decreases the turnover. So this slide is just reiterating what I said previously, but this is more so focusing on like why safe nurse staffing matters to everyone, right? It's not just for us nurses, it's not for just us patients, it's multifactorial. So there's safer care for patients that comes with fewer falls, less medication errors, and less infections. It reduces that burnout and moral injury for nurses, and like I said, decreases those turnover rates. And it also increases that family's confidence in participating in the healthcare team, and supports that safe discharge planning by ensuring education has been delivered effectively so that they feel prepared to manage that care at home. And so moreover, it also decreases organizational costs when it comes to recruiting staff and training and overtime, and ultimately provides a more stable and experienced workforce in these skilled nursing homes that you would want your loved one to be in. In this slide, I list some oppositions to staffing ratio legislation. We have the American Hospital Association and American Healthcare Association. They state that labor crisis would be exacerbated and worsen the current crisis access to care, and that mandating staffing levels to be a one-size-fits-all approach does not necessarily account for unique and complex needs of residents. American Organization for Nursing Leadership also stated that static mandated ratios does not account for interprofessional teams and collaborative practice. And so they're advocating more so for nurse managers and direct care nurses should decide on that staffing need and ratio. And lastly, there's healthcare facility administrators that may be potentially strained when it comes to legislation of staffing ratios, especially in rural or underserved communities. So this poses a utilitarian conflict, short-term financial burden versus long-term patient benefit. All that to say, opposition is largely based on concerns about flexibility, patient-centered care, workforce limitations, and the financial impact. On the contrary, there are some organizations that do support that policy reform, namely American Nurses Association and National Nurses United. So both of them encourage nursing leadership and advocacy for safe staffing ratios that promote patient safety, improve quality of care, and also support nurse well-being. So some of the statements that they have made: protect patients from complications that arise from miscare, allows nurses to utilize their full expertise, education, and licensure. And it's just recognizing that value in optimal nurse staffing that extends beyond like the primary stakeholders, but also supports financial and operational success of healthcare facilities across the board. And additionally, American Association of Retired Persons, more commonly known as AARP, their argument is that the minimums, like staffing minimums or staffing legislation minimums, are just the beginning of what we need to meet the care needs of residents across the nation. So what's the count of safe staffing? What's the cost? How big is this really? So CMS states that they like to throw in numbers with their PPDs. I'm not sure if anybody else has heard. But to cut it simply, they've estimated the cost to be about $10 billion. That would require about approximately 187,000 additional nurses. And there's risk for nursing homes to reduce their census and reduce the total amount of patients that they would accept. which they're saying will affect about more than 200,000 residents and displace them. However, there's also research done by the Long-Term Care Community Coalition, arguing that most nursing homes are for profit and they have net revenues of 126 billion and a profit of 730 million in 2019. So I can only imagine how it's grown since then. And they make a good point by pointing out those hidden profits. They have rents, they have management fees, they have therapy, and all of those could fund more staff and potentially boost that PPD by 29%. So just increasing the amount of patient care finances allocated through each and every level of the nursing care staff. So why did I include this slide? These financial realities matter in implementing safe staffing ratios because they show us that healthcare staffing is an issue, fundamentally like structural. Ethical practice demands that facilities allocate these resources transparently and prioritize resident safety over profit. We just need that investment in the workforce to be able to deliver that higher quality of care. So, having considered the costs and benefits, we turn to implementing the change. How can we address this issue through legislation? So, for my project, I chose to reach out to our local leaders. In a state level, contacting them directly, attending hearings, supporting advocacy campaigns. We need to know who represents us and how to reach them. So, solutions at a state level can be better tailored to reflect what we need. And it can also serve as a pilot program to potentially strengthen our argument at a federal level. So in this slide, I listed some of our state representatives, mainly in District 24, which is mostly, I want to say, kind of central Phoenix. So you can email them, you can call them, or you can send a letter to them. Like I said, contacting these legislators is a direct action. And any citizen can take to advocate for change and improve safe staffing in nursing. Oftentimes, my rationale for the state level advocacy is that addressing these issues at state level first adds to that strategies because we can pass these laws faster than Congress can. And because we have that closer ties to our local communities. So we can be a pilot for that larger change and build credibility and momentum, and support nurses and residents alike.